Right, so good morning, everyone. Before I get started, I just ask that you hold all questions until I reach my designated question slide. And then at that time, feel free to type any questions that you may have for me into the chat box. I'll be monitoring that. So thank you again for being here. I am Caitlin Burns, a dietetic intern from UWGB, and I'll be sharing some insight on enteral nutrition options, those being whole food blends and commercial formulas. This topic idea came to me in a meeting during my hospital food service rotation. I had not heard about whole food blends previously, but once I did, it really resonated with me. I realized eating whole foods was a privilege, and those who struggle to tolerate oil feeds deserve the next best thing, and that is whole food blends. First off, if you're not familiar with the reasons enteral nutrition is used, it's because either the body is not able to tolerate feeds by mouth, and caloric needs are then not met by oral consumption. Enteral nutrition is the next step used to provide nutrition to that individual. I'm sure you heard of the common phrase, use it or lose it, which is true with the GI tract. If the GI tract was not utilized in some way, it could potentially lose its ability to absorb nutrients effectively. There are a variety of enteral tube placements that range from starting in the nose or the mouth that go to the stomach or various portions of the small intestines as well. These placements aim to utilize that entire GI tract, or at least the working portion of it. Some terminology that you might hear me use today is HEN, or it might be shown in the slide, which stands for home enteral nutrition, BTF, which is blenderized tube feeds, and CF for commercial formula. And why does it matter? Well, this conversation is important because upcoming dietitians or already registered dietitians, we often preach to our patients and clients the importance of eating minimally processed foods, whole foods, and including a variety of foods into our diet. But unfortunately, when it comes to people that require enteral nutrition, this seems to be forgotten. When you think about enteral formula, what comes to your mind? In mine, I usually think of a square carton that reads Osmolite 1.0 or maybe Jevity 1.2, maybe even an aluminum can that says Nepro. But whatever came to mind, I'm sure the shelf life is at least a year long, right? So that in my mind kind of stands out as a highly processed commercial formula. And patients receiving these formulas day in and day out are only consuming the ingredients that are listed on the back of the carton. And those typically are hard to pronounce, and they're not chicken, they're not blueberries. So, not to mention, these formulas are used for patients that have a wide spread of diseases or medical concerns, and that's kind of the opposite of an individualized nutrition care plan that we usually strive for. So, that's why it's important. Some of the pros that are associated with blenderized tube feeds is right off the bat, according to Martin, ETFs have increased patient tolerance for their feedings when on blenderized tube feed compared to commercial formula. There's also a decrease in gagging and retching when it comes to blenderized tube feeds. Later, I will touch on some other GI symptoms that were improved when blenderized tube feeds were utilized in a study that was completed by Boston Children's Hospital. Additionally, the same study touches on some benefits that includes the microbiome that are often thought to be because of increased fiber content, which is a nutrient that's lacking in most American diets anyway. Common concerns that are mentioned about blenderized tube feeds in a variety of articles include the microbial contamination risk with home enteral nutrition, which will be discussed later. There's the possibility of occlusion or tube clogs, which can be fixed by utilizing a larger tube size, according to Weston, or a third common concern is the nutrient calculations that come along with blenderized formulas. But however, patients that use these feeds can utilize nutrient trackers like MyFitnessPal, just like any other client of yours. Without further ado, I'm gonna jump right into the research, deeper into blenderized tube feed, because our profession is an evidence-based profession. The first study, titled "The Use of Blenderized Tube Feeding in Adults and Pediatric Enteral Nutrition Patients," sought out the experts on this topic, being those that have utilized blenderized tube feeds for an extended period of time. Instead of reinventing the wheel, we can learn from those that utilize this form of enteral nutrition and analyze their blenderized tube feed patterns and understand what is working and what might not be working to make this diet sustainable for them and others. One of those patterns noted was that some patients don't utilize blenderized tube feeds for 100% of the diet. They combine blenderized tube feeds with commercial formulas, but they benefit still from the variety that they receive from the blenderized tube feeds and the convenience of the commercial formulas, which in reality, we see this every day in clients that eat orally as well. Sometimes they have the time to prepare a stir fry with 4 different vegetables, but sometimes it's easier to grab lunch through the drive-through too. So this is just reality. The methods that the Ole Foundation used, well, their primary focus is to enrich the lives of patients dependent on parental and enteral nutrition. In this study, there were 216 participants, which is only 5.8% of all the members in the Ole Foundation. Of those that participated, 125 were under the age of 18 and 91 were over the age of 18, which was a significant difference. The participants took surveys asking questions on the frequency of their feeds, the type of formula they used, and how often each type was used, whether they worked or not, and also demographic information like age. One significant result that came from this study was using commercial formulas was more likely to lead to weight loss than blenderized tube feeds. Other results that were significant are boxed in red, like mentioned on the last slide. The breakdown between pediatrics and adults, as well as weight loss, were significant. Another result that seems obvious now, knowing that the age breakdown, and that's the age breakdown. As you can see, the pediatric group was quite young, with an average age of about 5.4 years. Blenderized tube feeds can be utilized with other commercial formulas and still adds variety. Like mentioned before, this was interesting to me. The limitations of the study also raised an interesting point about workload. So obviously children don't work, and they also may not have answered this survey. The parents might have had to help. The survey questions, or at least the data reported, focused on the length of use and the type of formula, but never any symptoms that patients experience, like bloating, gagging, or vomiting. But it explains in the discussion section that blenderized tube feeds may decrease these symptoms. Similarly, the length or session of nutrition education that these patients may have received was never asked about, and the discussion also mentioned difficulties on planning a blenderized tube feed diet regimen. It is possible another study could be done to look into some of these other characteristics to be more conclusive. The second study done, like I mentioned, that was at Boston Children's Hospital, because the last study indicated that a majority of patients utilizing blenderized tube feeds were in fact children. I looked into this study done at Boston Children's Hospital. The study objective was to determine whether clinical and patient-reported outcomes differ in children receiving blenderized diets compared to conventional formula. This study gathered information based on formula nutrient content and quality of life and hospital admissions. In this study, there were only 70 children. The study was able to pull from diet history and review patient charts, as well as a few questionnaires that were completed. Each patient or their parent completed it. 60% of those participants relied on blenderized tube feed for at least 51% of their nutrient needs, and 40 of those participants mostly used commercial formulas. Between the two types of formula, the one nutrient that there was a significant difference was the amount of fiber, and this was significantly greater in blenderized tube feed formulas. Those participants that mostly relied on blenderized tube feeds for nutrition also experienced less limitations from GI symptoms. Some of these symptoms that were compared are found on the chart, including stomach pain and diarrhea symptoms. If you look at the p-values on the far right, none of them besides satisfaction of feeding regimen are significant, which favors blenderized tube feeds. Also, less GI limitations were reported with blenderized tube feeds compared to commercial formulas, and if another study were done with more participants, it's possible that some of these values could become significant, but for now, this is the concrete data. Hospital admissions was another comparison which could reflect overall well-being of the different participants. Although no comparison was significant here, there were less admissions from patients that consumed mostly blenderized tube feeds compared to those utilizing commercial formulas in all of the recorded categories. The difference in the fiber content was a big find. It's possible that the increased fiber content in blenderized tube feeds could be the reason GI limitations are decreased in children who use blenderized tube feeds, but no relationship was directly compared in this study. Another interesting find that I mentioned earlier was the small sample size. With more participants, some of this data could be more conclusive, but we will just have to see if further studies look into that. Finally, an appendix was added to the study afterwards that categorized children by the placement of their tube feed. This chart indicated more blenderized tube feed patients had tubes placed further into their small intestines, whereas children eating commercial formula had placements into either their stomach or a more proximal portion of their small intestine. This also may have had some impact on the results of those GI symptoms talked about, but again, more research will be needed for that. The third study that I looked into addressed the microbial content concern that was mentioned on the cons page earlier. This study was able to mimic knowledge and resources of a patient that is new to utilizing enteral nutrition because they were volunteers that had stated no background in nutrition. The only equipment that was needed in this study as well was a blender, microwave, and bleach. The study concluded that nearly all samples of this home-prepared blenderized tube feed were within the acceptable microbial range. This measured in CFUs, which is a colony-forming unit. This is the recipe that was utilized. I wanted to briefly show it to you to show that the foods are rather common, such as whole milk, chicken, blueberries, broccoli, oats, and more. One ingredient near the bottom that might stand out to you as cod liver oil, and this ingredient is similar to a fish oil supplement and can be found in most drugstores or vitamin shops. For this study, 50 random subjects who volunteered for this study were given specific sanitation procedures and the previously shown blenderized tube feed recipe to follow. To prepare the blend, the subject utilized the basic kitchen appliance mentioned before, such as the microwave and blender, and then the last step that they had in their directions was to send their sample sealed and labeled to the lab for a serial dilution. This picture here shows a little more what a serial dilution is, and it is a series of dilutions used to reduce a dense culture of cells to a usable concentration. Each dilution reduces the concentration of bacteria by a specific amount, and then that specific amount would be looked at for on an inoculated plate and that would be one that is within 300 to 30 CFUs. This sample then can be used to calculate the number of CFUs in the original sample. First off, the microbes were present on every single sample, and even the baseline sample at 0 hours of incubation. This shows that there are already microbes in our food and in the air. There are also microbes floating around in the air, like I had just mentioned, and this is exactly what they were. The colonies that were looked at on the 0 hour plate were identified under a microbe, and these are commonly found in the air. I mentioned before there were a number of CFUs which are classified as acceptable, and that value in a single sample is 10 to the 4th CFUs, and if the sample is done 3 times, it is 10 to the 3rd CFUs. On the next slide, you will see only 6 samples exceeded this limit. It was later found that the milk utilized in the sample that produced more microbes was much closer to its expiration date than the other samples, and this being said, it is important to look at dates in any food prep that is done and pay attention to other food safety and sanitation things as well. Here's the breakdown of samples in the range of CFUs at 3 different times of incubation at 0 hours, 24 hours, and then again at 48 hours. Interesting finds from this study is that no IRB approval was needed for the study because of the way it was conducted. All participants were over the age of 19. They volunteered to participate. The tests they were completing were at home, and then the lab was within 15 minutes of their home. No demographic information was also collected, and this could be because the research parameters were already so specific, but education level or income were not reported, which could have been interesting to look at. Another find was that I already mentioned a few times, but the instructions and equipment utilized were really targeted to mimic the entry-level enteral nutrition user. So coming full circle here, how does this affect you as an RD or you as an aspiring RD? This strategy used to be the norm. If you required enteral nutrition, blenderized tube feeds was the only option until, like many other things in the world, we commercialized for people's convenience, and commercial formulas was one of those things that came out of it. It may also apply to you as an RD one day if a client asks you for assistance in calculating blenderized tube feeds, if they have heard of the benefits that it has to offer, and they are interested in trying it. Or it is also possible that you have a patient that has not progressed in oral feeds or in enteral nutrition utilizing commercial feeds, and blenderized tube feeds might be one of the last options that you can suggest as a professional. So some of the main takeaways is that real food really does work, whether it's consumed orally or enterally. So we should use whole foods and the GI tract if at all possible. The research also supports the use of these blenderized tube feeds, which is key in our profession because it heavily relies on evidence-based finds. And finally, no option is 100% risk-free, and food safety and sanitation is always important to follow. All in all, with the support of science and what has worked historically, consider blenderized tube feeds because they could offer benefits that commercial formulas don't offer us. So thank you all for taking the time to listen today. If you have questions, feel free to drop them in the chat and I will start going through some of those. And also I will just go through some of my work cited here for you.
Awesome job, Caitlin. Thank you. Everybody, please note that I shared the presenter eval in the chat. Feel free to fill that out at your convenience.
And it looks like we do have a smaller group here, so if you would be more comfortable or want some more interaction and you would like to unmute and ask a question, that is totally fine as well. We have a little extra time for questions today. All right, Michelle asked, do studies indicate why some people gag and retch with commercialized versus blenderized tube feeds? In that second study that I mentioned, it was kind of one of my interesting finds, so definitely something that might need to be looked into more. Again, like mentioned in the slides, it could be related to the placement of the tube feed. So like I said, usually the blenderized tube feeds have a placement of their line further into the GI tract, which could result in less of those GI symptoms. But specifically why it wasn't mentioned, so that's something that I could look further into. Thank you for the question.
I'm just going to ask instead of typing. This is Michelle again. In the first study, there was, if I remember correctly, there was weight loss seen with the commercialized formula versus the blenderized. Was there any speculated reason why that may have occurred?
No, that is a good question. I'll just kind of go back to these slides here to see. So as you can see, that last bullet point there, the weight loss with enteral feeds was more prevalent. And no, they didn't really say why. It could be because some of those ingredients are whole foods to us. They compared the nutrition contents like the caloric needs and the protein, and they were all they tried to keep it very uniform so that they could see where some of these differences were, and some of that just comes out in the type of food that is being consumed. So it's just easier for the gut to use up the nutrients from some of those whole foods compared to some of those commercially blenderized foods and ingredients. Any other questions? Otherwise, you're free to go take a quick bathroom break while we have a little time before we jump into the next presentation. Otherwise, I'll stay on here for a couple minutes if there's any further questions. All right. Thank you all again for listening today.